Hello, today I'm going to be talking about my proposed integrated awareness and accessibility program for maternal care in Pakistan. For sure, maternal care is one of the most important aspects that a government or a governing body has to consider or keep in mind when it comes to public health or public safety. On the right over here, I've presented a general map of Pakistan showing how difficult general care accessibility is, which can be a good representative of maternal care accessibility, which I'm going to be talking about in the next coming minutes. Um, okay, so Pakistan has a severe maternal and infant health crisis. For example, Pakistan and it's supported by studies from UNICEF, PMMS, and Department of Health in Pakistan as well. And the main problems that are arised in Pakistan's healthcare system can be broken down into three aspects. First is the accessibility of care or basic care. Pakistan has a sharp shortage of skilled maternal care providers. That's because there's no regulations when it comes to staff who are hired into these hospitals, public hospitals, which I'm going to be talking about as well. Only 52% of births are attended by skilled personnel in rural areas. Whereas there's a higher coverage in urban areas. And the reason for that is most people in rural areas, either because of lack of faith in the public health system or just cultural sensitivity of childbirth, don't opt for public health public hospitals. That's why they end up just delivering babies at home, which is very concerning as well. And then, of course, there's delays in reaching emergency obstetric care due to long travel distances. Primarily, Pakistan is divided into districts, and by law, every district has one at least public hospital. But the problem with that is that since Pakistan is a very agricultural country, the districts are very big, and the houses, there's no residential communities, there's no concentrated residential communities for the most part in Pakistan. So the hospitals are, even though they could be in the commercial area or the center of commercial area, people live close to their fields and close to their farms, which are then very far away from the hospital. So travel time is a huge concern for these people who live in the villages or in rural areas. When we're talking about health outcomes, Pakistan's maternal mortality rate is 186 deaths per 100,000 live births, according to Pakistan's maternal health survey that was conducted in 2019. This, when compared to the United States maternal mortality ratio, is actually 10 times higher because the United States maternal mortality ratio is 18.6 deaths per 100,000 live births. So there's a 10 times increase, which is very, very concerning and is significantly below what our standard development goals are laid down by WHO are hoping to achieve. Other than that, the neonatal mortality rate, that is death within the first 28 days of birth, is also 46 per 100 per thousand, and then there's other major causes are hemorrhage and sepsis, etc. The main thing to note over here is that these differences exist more in poor households as compared to less in richer households, and this also extends to the differences between rural and urban areas, which brings me to my next point. The underlying problem is the rural-urban disparity over here. Though there are many factors, the strongest and the most consistent pattern is the fact that people are distributed, that these problems are much extreme when it comes to rural areas because the reasons are much extreme, which I just explained. Um, for example, rural infants are two times more likely to die in the first month of life, according to UNICEF. There's limited awareness of the risk of home deliveries because of sensitivity of the topic, and then there's an access gap. There's longer travel time, just as I mentioned before. And the Pakistan maternal mortality survey reports that most maternal deaths in rural districts result from preventable causes, especially postpartum hemorrhage and sepsis, which I discussed as well. So the point being that these problems are very much targetable. These deaths are very much preventable, and that is where my proposal comes in. That is the specific thing that I'm hoping to target. Now, the general strategy of the solution would just be, first of all, to identify these areas where the problem is concentrated, and I expect that to be rural areas. The hotspots, or more specifically, the areas that I'm hoping to target will be with high home deliveries, low ANC rates, and severe neonatal outcomes. And then I'm going to identify some pre-existing rural outreach system that has been established for another program, and then use that or integrate that into my program. So to cut down costs as well. And then my long-term strategy would be to solidify whatever infrastructure I hold or I propose so that it can be independent of whatever infrastructure we were using before. All right. So my first step would be to identify the pain points or identify the areas within Pakistan where the intensity of the problems is highest. So I'm going to use these indicators, NMR, MMR, neonatal mortality, maternal mortality, skilled birth, and all of these factors are going to count to work. And the sources I'm going to use are going to be credible sources, which are established by the Pakistan's government and the Pakistan's health departments, and all these surveys I've listed down over here as well. And then I'm going to normalize these indicators. I'm going to, so normalization basically means since all of these rates are at a different kind of like scale point. Normalizing them basically means I'm going to take the two extremes and then fit them all into a scale from 0 to 1, and then I'm going to weigh them by importance and compute a personal risk score per district. Now, the highest risk score, the areas with the highest risk scores, which I'm expecting to be very conjugated or congested as well, because it's mostly going to rural areas or rural districts would be my starting point. Now, then my proposed solution is that I'm going to use the polio epidemic, the established infrastructure already that's been laid by um, for the polio epidemic because it's one of the biggest problems that Pakistan has faced in the past 20 years or so. There's like an infrastructure that has been laid down. People go and visit every single home within Pakistan and deliver polio shots. So there's an entire preventative kind of infrastructure and staff and everything, offices, everything is laid down already. There's 300,000 plus community health workers. Mostly they are women. Why that's important, I'll come to as well. They cover 99% of households, especially rural areas. And there's an entire flow of information that's already existent. My approach would be to deliver maternal health pamphlets. And then I'm going to train these workers to the targets that I'm hoping to achieve. We're going to identify pregnant women, and then we're going to refer them to nearby public hospitals to avoid home deliveries. And then we're going to flag high-risk pregnancies because most of the women in Pakistan in rural areas do not understand the problems that could arrive before birth, and are very heavily reliant on like cultural kind of remedies, and not they don't trust the health system that much. And I'm going to come to that as well. Why it's applicable, because workers will trust female members of the community, and from those people from within those communities will be more trustworthy. So this way we won't be asking them to come to the hospital, we'll be providing them the solution. And evidence shows that households are more receptive to information delivered by consistent familiar health workers, so that goal will also be established with our program. um, yeah, so our specific strategy would be, first of all, outreach, training polio workers. We're going to add a short standardized maternal health checklist for their visit because they have a checklist for polio. We're going to add that to their visits for every household. Then we have an education strategy. The pamphlets are going to be in specific local languages, which are more than 50 in Pakistan, even more. We're going to try and make those pamphlets very scalable to whatever household we provide them to, the main language being Urdu. In the pamphlets, we're going to talk about the risk of home deliveries, the importance of facility births, danger signs during pregnancy, and benefits of birth spacing. So we target because Pakistan is also facing a population crisis. And then we're going to train polio workers in sensitive communication because these are very sensitive topics. And then, of course, that's going to be a repetitive process. For referrals, polio workers refer pregnant women to nearest public hospitals. We're going to establish birth booths within these public hospitals, and then, of course, the workers are going to take note of any risky situations, and then create a reporting system to track referrals as well. As far as the long-term solidification is concerned, but some potential challenge that we could face when we're launching this program is that there could be some areas which are not covered by the polio infrastructure, but still have a high mortality rate. Another barrier that we could face is that this topic, the birth and child mortality and family planning, is a very sensitive topic. That could be a barrier when it comes to rural areas. And then um, there could be weak facilities available in some areas. Some solutions that we could think of in the long term would be to use wherever there's no, let's say, established infrastructure already, we could use an alternative campaign. Then we can culturally tailor our message to avoid the cultural. And then if I mentioned before as well that repeated visits from the same people could be a very good solution because trust is a big factor within rural communities of Pakistan. And then we could put in some funding later on if this program seems to be working and successful into upgrading these facilities, or the capacity of these facilities, which will be mostly public hospitals. Our long-term ambition for this project would be to make this an independent infrastructure, move it away from the polio or any other infrastructure that we're using, and then develop a separate trained workforce and employ people from within the rural communities. And then we're gonna develop this as an independent institution to track the rates of natal mortalities that are occurring and hope for positive outcomes. As far as the funding strategy is concerned, there's two main kinds of costs that can occur: structure and then operational costs. For training the polio workers and providing them small incentives, I've used the BMJ Global Health Survey, which estimates that in low and middle income countries, a median of $6 per capita per year should be um, enough for, let's say, any community outreach program, given that polio is already has an outreach program. So this is a upper end that we're looking at. So for a typical rural district of 500,000 people, the annual program expenses could be $3 million, which is, again, an overestimate, just to be on the safer side. And then operational costs, printing, communication, referral tools, all of this, structure and facility support, the birth booths, and then clean delivery and hemorrhage management protocols. The clean delivery kit and the essential birth equipment upgrades would cost anywhere between $200,000, $2,000, $500,000 per rural facility, according to the Copenhagen Consensus, which also targets lower middle income countries. And then if we're starting with 100 facilities in high risk districts, that's going to be around $250,000 on average estimated costs that we're looking at. So again, cost benefit analysis is going to, of course, if we're having a preventative approach, the post neonatal complication costs are higher, so we're saving on that. There's a lower program cost compared to return. Um, and then we're of course leveraging existing polio infrastructure should not be that much of a hassle when it comes to finances or public funding. And then we of course have long-term economic gains because preventing maternal deaths avoids significant household productivity loss. And since Pakistan is an agricultural country, most of the farming is reliant on within the household on members of the household. So it's going to be having a long-term positive effect. That's it. Thank you so much.